It's 2023, and Andy and myself are getting ready to give you the biggest update that we've had in the past 7 days of the year. There's loads that's already been happening over the Christmas and New Year period, and in particular in the past week. And we're going to start by tech enhancing your primary care and learning. So let's get cracking, shall we? Hello, EGP learners. Welcome to this episode where we're giving you our update on what's been happening in general practice and the NHS in the past few weeks as we kick off 2023. But how's it going there for you, Andy?
Yeah, it's pretty good over here. Yeah, excited to be back. It's a new year. Hopefully 2023 will turn out to be better than 2022, but we'll see. Got my fingers crossed.
Fingers crossed. Andy and myself did go through our kind of like awards of 2022 in our last episode, and we'll put the link to that towards the end of this one if you want to check that out, including our predictions for what's going to happen in 2023. A little bit doom and gloom, weren't we, Andy?
A little bit, but you never know. We're often wrong with the predictions, so hopefully we'll be wrong on the downside and we'll get some upside. We'll see.
But we're going to get started with today's episode, and we're covering a variety of different topics that have been happening in the past few weeks in particular. First of all, we're talking about the impact of the really hot topic stuff, which is the ambulance strikes that have been happening. And yeah, it's been a bit chaotic, hasn't it, Andy, that everything that's been going on?
Yeah, I mean, I think we talked about this in detail in sort of the last update episode that we did. Ambulance organisations in different parts of the UK, but not everywhere in the UK, have been on strike at certain dates around Christmas and New Year, and that's because of the enormous pressure that they've been under. They're feeling that they're not resourced enough to really meet patient needs, and also that the pay has not kept up with inflation for a long time, and then it's very difficult to attract and retain people in those jobs. So they felt that it was unavoidable to strike. Obviously, this is something that was going to have quite a big impact on patients, definitely, and also those other parts of the NHS. Yeah. And I think we identified that general practice might experience some difficulties, and certainly noticed that this was going on, essentially. So really big for general practice, I think.
Absolutely. And I'd love to hear from our viewers whether or not you've noticed the impact of the ambulance strikes in your local area, because it has been variable depending on where you are. I guess this article by Paul is some of the experiences that have happened across the country. I think there's definitely been an adjustment that many people have made in terms of, the advice they've been having to give to patients. There have been situations where clinicians are having to transport patients directly themselves because there isn't an ambulance that can come. And in particular, there's various situations where that may have occurred, or that they're directing them to take things like taxis or public transport and that kind of stuff. And obviously that has an element of risk that comes with it, because I guess it's worth covering this briefly. There are, from what I can tell, there's 3 times when you would call an ambulance. There's one that's based on medical need, various different things. Obviously you've got your range of that when it comes down to heart attacks, strokes, which obviously are what your category, 1 and 2 ambulances, where you just need that urgent response really quickly to get that patient to hospital as quick as possible. They can get treatment, and they're the top kind of level ones. And there's been a commitment, I think, from the ambulance departments to try and maintain that as much as possible. And then that comes down to the various different other types of medical situations where you would need to transport patients. So, for example, I guess patients with injuries, bleeding, that kind of stuff, where, that they're not safe to transport via another route and things, or unwell for other reasons. But then you've got other types of transport situations, which I thought were quite interesting. I think these are the ones where there's probably been some adjustments. So you've got those ones where there's an element of kind of risk in terms of where the patient needs to be transported to hospital. So I guess one that came to mind in my view, and I don't know what you think about this, Andy, was the situation of patients with a possible PE, pulmonary embolus, but aren't decompensated, where it's not necessarily significantly infected them. But our protocols normally say that those patients should be transferred by ambulance, not making their own way to hospital. I don't know how you felt about that kind of situation and stuff.
Yeah, it's really difficult, and obviously, patient makes their own way to hospital means all sorts of different things. Obviously, we can't be having people driving themselves to some patients want to do, but you can quite easily tell them not to do that, although often they don't want to get a taxi. Yeah, left and all sorts of that. But it's a lot easier if there's a caregiver with them who can take them, and you can give clear instructions to escalate care and call 999 for a blue light emergency ambulance if they deteriorate. Sometimes patients get there by public transport, which isn't a taxi, which I don't think is is really appropriate. Yeah, I always have mixed feelings about it, but you have to balance that now with the fact that if you call an ambulance, particularly on a strike day, but actually more often, often on a non-strike day,
yeah,
they can have a really long wait, during which they deteriorate, and at the practice or in their own home, there isn't the facilities there to manage them if they deteriorate. So, yeah, I know in this article from Pulse, a number of GPs were saying they're sort of normalising, telling people to make their own way safely to hospital. That's becoming a normal part of their practice, and I must admit, I'm doing a lot more of that now as well, or actually illustrating to patients the choice they have between potentially waiting a long time or making their own arrangements to go with clear sort of safety netting and plans for escalating care. That's become my norm now, but helping them take that risk.
Absolutely. Now, I think that's one of the challenges, isn't it? Because you've also got that other cohort of patients where they need what's called assisted transport, where, potentially we're talking about the quite frail elderly or the bedbound patients for other reasons and stuff, where they actually need somebody else to physically transport them because they're not able to go. And that's a really complicated category, I think, because of the situation, because we know that they may not necessarily need the medical urgency of an ambulance, but they need the assisted element of an ambulance, and their carers and that kind of stuff can't facilitate that for whatever reason. And particularly, I think I'm thinking about the bedbound ones, because if you're not bedbound, theoretically, you could get yourself into a car, although it may be really, really challenging to do so. That cohort, I think, are the ones that we're really struggling to advise and stuff and what to do and things.
Yeah, it's really difficult, and you've been hearing some very difficult stories about relatives putting people on planks of wood and putting them in the back of estate cars and vans and taking them to hospital. It really sounds really dreadful. But actually, I'm not necessarily hearing that those are particularly on strike days. Some of that have been on days when there has been a full service, but just very, very stretched services. Yeah, really, really difficult times. Have you been noticing an increase in communication from ambulance crews, bringing into the practice for perhaps some decision support?
No, I haven't. Interesting. I've seen a drop in it. I think they're just so overloaded that they're struggling to know what to do. And in that situation, the easiest option is to transport potentially the patient. But then obviously they're having to deal with the backlog of once they're in the hospital situation, that then they're caught waiting to obviously get clear. And that we know is one of the problems. We've heard loads of stories of hospital waits outside for ambulance crews and that kind of stuff, because they can't offload the patients because there's no space to offload them and staff to take that over and things, and it feeds into the problems. There have been some stories about news media and stuff about ambulance crews trying to wait to speak to a GP in a practice and stuff, and obviously there's just across the board there's workforce challenges that are contributing to all of this. I think really important from my perspective that this is absolutely not a criticism of our paramedic colleagues, the fact that they are taking these measures, because that's how crap the system is right now. Let's be honest. They're doing the best they can, and they're doing what they can to try and maintain some element of safety. And unfortunately, we've now got to a point where, in order to make hopefully more safe in the future, we're having to do things that are causing an impact on the population as a result of it. And we'll see how much difference that makes in the future.
Yeah,
but I think it's a really challenging situation that many of us are facing, and actually patients, there's that element of what do you do. I think also worth noting for clinicians that there's some element of risk here as well. If a patient does go, for example, on a taxi, what happens if they deteriorate whilst they're in the taxi? What if they go by public transport? What happens if they deteriorate whilst they're on a bus? If you take them, what happens actually if they deteriorate? Because often, clinicians don't have emergency medications that they would need to support a patient in that situation. And really frustratingly, there is a considerable element of investigation that happens if a patient actually dies in the presence of a GP, which actually has some risk elements with it as well that plays into this, that actually, there's that safety element, there's that aspect of what do you do in those kind of situations. So all deaths with a GP present at the time actually need to be reported to NHS England and CQC, which, creates a situation that's even more complicated that happens because we're not meant to be an emergency response service.
Absolutely.
I think people forget that at times.
Yeah. No, well, we often try and remind people, actually, we're not an emergency service, because often people say, well, if you can't see me this morning, what happens if I'm dying? Often patients say, and we just have to remind people, we're not an emergency service. That's not what we are here for, either now or traditionally. The interesting thing that I found is, I think at my surgery, I think we have probably experienced over the last few months, not necessarily during the strikes, increased contact from ambulance crews for decision
Mhm.
support. And I think the interesting thing is actually most ambulance services within their contracts are supposed to provide that decision support for crews themselves within their service about whether someone should remain at home or not. So we always remind our own clinicians that they shouldn't be put in a position of making that decision, and
Yeah.
that's the ambulance crew supported by their own medical teams within there. So, but we've had it, they don't always ring for support about the decision to stay at home. You know, sometimes it's, can we arrange an alternative way of treating this patient together that avoids a hospital transportation and admission, and
Yeah.
we're more inclined to play ball with that for the, you know, for the good of the patient, really. And probably we had an increase in requests for home visits. It's not really ambulance crews, but sort of we've had a few instances of 111 or the call handlers were saying, no, not an ambulance, you need to contact your GP to get a visit. And often these patients are actually in a grey area where actually we reassess and we actually, no, you probably do need an ambulance. You know, actually we do need to call you an ambulance.
Yeah.
That might not have been appropriate. So just a symptom of that system being under pressure. But I think the sad thing is the strike days, I don't think have been particularly different to the normal days. And I think that just highlights how bad things are on a normal day.
It's really interesting, Andy. So there was, I recently put out a tweet about this, that, you know, there was a call that we should have safe staffing limits for when there are strikes. And, you know, I commented on the fact that that'd be great, but our current staffing levels on a normal day are below what is safe for a strike level in some areas. So actually, what do you do in that situation? So this is the key problem we've got within the NHS. The situation is so bad when it comes to staffing and workforce and things, that even on the strike days, I think we may actually have, in some situations, more staff than we've got on normal, you know, days. And I've definitely had that days. On a normal day in practice, we've actually had less staff available than on days where, you know, potentially we would have more challenging, like holiday times and that kind of stuff and things. And that's just the nature of the beast. And that's one practice. Okay, fair enough, that doesn't hit the media and stuff. But actually in the hospitals, I suspect that's a common problem, because they are having increasing more problems with challenges with recruitment, workforce retention and all that kind of stuff, because of how difficult it is. And we're going to come on to the strikes that are coming soon as well. We've covered the historic ones that have happened and that kind of stuff, but we're going to in a second talk about more ones.
I think, Andy, on strike days, I think patients often get the message, and, you know, demand may go down.
Potentially, it's not as bad because people are aware of the fact that there's a problem and they use the service less. But then that obviously unloads onto the following days when there isn't a strike, and that causes even more pressure.
Again, the other question is: so is the ambulance service the real backlog, though? Because you know, patients queue up when they get to A&E. Patients queue up when they're in A&E to get a hospital bed, and they're kind of queuing up to get out into, you know, safe social care packages and locations. You know, is A&E, you know, is our paramedics really the backlog? You know, the bottleneck. Sorry. Anyway, there's just so many bottlenecks.
I think that raises a good point. I mean, if we go to some of the comments, Deanne Fern mentions that also if they go by themselves, they have to tackle the A&E reception, maybe a big queue, and what if there's strokes and rapid, you know, delay to rapid response and that kind of stuff. So it feeds into that comment you made about the fact that actually the backlog is not necessarily the ambulance crews. It's the service provision that's able to happen by hospitals that is then caused by the delay of patients being able to be discharged safely to home, which is then caused by the fact that we just have not enough funding for social care as well as healthcare currently in the country. And I know that obviously many politicians are saying, oh, well, we've given the NHS, you know, a 50% increase over the past few years and that kind of stuff. Well, actually, if they'd been kept up with, you know, the previous 12 years, it'd be considerably more. It's just that they back-ended it in the past year to try and offer, and the problem is that takes time for it to have a benefit. It doesn't change things instantly. And actually, you know, it's still underfunded compared to where it should have been if funding had kept line with what it should have been, you know, over the past 12 years and stuff. And that's not just talking about pay, that's talking about funding across the board and stuff. So it's really interesting in that sense and stuff. But Deanne also comments about the fact that I've been involved with a pilot with the LAS, so local area, I assume, system. And interestingly, they had quieter the day after the strike. Interesting.
That is interesting. Wonder why.
And Stephen mentions, you know, given the volume of consultation taken in primary care, do you think there's been enough coverage in the media about what's happening in general practice, as A&E seems to get all the headlines? Well, we're coming on to coverage of general practice in the media in a second, so we'll cover that one and stuff shortly.
Yeah,
but,
I think I think Stephen makes a really interesting point, and it might warrant a future episode actually, because I know during the pandemic locally, we developed within general practice a reporting system to indicate the stress on general practice, because we often get black or diamond or platinum alerts from the NHS trusts about how overwhelmed they are, but there was no way of communicating the level of demand and capacity and mismatch in general practice. So we have this Opal rating system, don't we, in Nottingham, and there are currently talks about whether that works or whether that is fed by the correct data. And actually, this issue of how do we know or communicate the pressures of general practice might be an interesting area to explore. So very good point, Stephen.
Well, it's really interesting. So one area that we're going to cover too in the later part of this episode, so the Devon area, the ICB and stuff came up with their own GP alert system, GPAS system, and that's had implications for them as a result of it. So we're going to cover that in the tail end of this session. So if you make sure you stick around, because we're going to cover some of that. But you're absolutely right, Andy. It's probably worth a more deep dive episode, and we could bring them on to look at that for you guys as soon. So let's have a look at that shortly. We talked about the paramedic strikes. I guess there are other strikes coming as well, aren't there, Andy? Do you want to take us through that?
I mean, the nurses have been striking. We covered that extensively in the last episode, and we'll probably revisit it going forwards. But more strikes on the horizon, and there's a ballot next week from the BMA of junior doctors exploring or asking them about the possibility of industrial action in the coming months ahead of the new negotiations around junior doctor pay leading up to April. So another area where we may be experiencing strikes, unfortunately. So what's going on? So the BMA are seeking to get the health secretary and the health service around the table to discuss an increase in pay. So the BMA are setting the stall out for junior doctors. So they're being really clear about the problem, and there has been a 26% decline in real terms junior doctor pay since 2008, 2009. So that's going back 15 years. If you sort of factor in the increases, yes, but that the increases have not kept pace with inflation in terms of what a junior doctor's pay packet will buy you. It will buy you 26% less stuff than it did 15 years ago. And they say that that's really not acceptable. That doesn't a country that values its healthcare professionals, that will be attractive to attract in the healthcare professionals from its own country into training programs and from around the world, which the NHS does rely on significantly to come and work here. And they're also talking about patient standards of care, also talking about patient patient experience and capacity, and just the general workload and working conditions for junior doctors, and that they're just not acceptable and not attractive and not workable. So coming up, what do you think about this, Gandhi? They did do some action a few years ago, didn't they, in 2016?
Yeah.
But have you got any initial reactions before we dig a little bit deeper into junior doctors' pay?
Well, I think, like you say, what they're campaigning for is something called pay restoration. So basically, the BMA are pushing for restoration of pay towards what it should have been. And it's important to recognise that, in some situations, junior doctors are earning approximately £14 an hour, which you can actually get considerably more of that when you're doing things like stocking shelves, for example, in supermarkets or other kind of work and things. And that's not to say that those people are being overpaid. They're being paid what actually inflation would allow them to be paid and doing a job for it. The issue is that by compensation, if you're looking at people who are working on medical wards, saving lives and that kind of stuff, is that an appropriate level to have our caregivers at? No. It also means, I've seen several comments of doctors who are saying that they just physically cannot earn enough money to pay for what they're having to do, because of the level of pay that they currently have. With obviously they have to pay for their exams, they have to pay for their memberships, other stuff as well, getting to work, because they are made to work in particular environments and distant. You can be on a rotation that puts you one element, one area of the county, and the next rotation you're in another area of the county. Huge challenges there. So the campaign for pay restoration similar to some other people, I'd probably say they should be campaigning for a pay rise, not pay restoration, not just bring it back towards it should be at this level, but actually considerably higher. But the key thing is that as of Monday, the ballots are opening for junior doctors specifically to then go out for whether or not they should strike. And there's been a suggestion of a 3-day rolling strike, effectively 72 hours in March. So just before the Easter holidays and that kind of stuff. And that, I think, will have an impact. The question of how much impact, you're right, that they did strike about 4 or 5 years ago. It was the big Jeremy Hunt battle that he had. And, in some ways he was hailed as beating the junior doctors by the contract that we now have as a result of all them. But actually that contributed to a significant element of what we're now seeing in terms of the current issues that we're facing. So it's going to be interesting, but I think the biggest thing for me is going to be finding out what happens with this combined with a nurses' strike. Because if you happen to combine a doctor strike and a nurses' strike on the same day, I think hospitals are going to have to shut because they're just not going to have the clinic, the staff to do anything.
Yeah, I mean, the nurses are protecting emergency care. The interesting thing about junior doctors' strike is because there are other grades of doctors within the hospital who can continue to provide care, your consultant and service grades, then they are saying that they will actually strike for emergency care as well, which I believe they did do last time in 2016. So that sends quite a potent message, I think. One of the interesting things here was I'm not sure people understand how much junior doctors actually get paid. And I had an interesting conversation with a 5th-year medical student in the practice last week. And I said, so how much are you going to get paid next year when you're a junior doctor? He said, I don't know. They didn't have any idea. And I think a lot of people go into medicine thinking, well, it's obviously a well-paid profession, and certainly it's better paid than many other roles that people have in society. But it's particularly interesting that the junior doctor pay isn't quite as high as 5th-year medical students might expect it to be after some exploration, and as the general population might accept. So sort of working just standard 40-hour contract, basic pay is about 28,800, so about 29,000 per year. That may sound a lot to many people, but it's interesting if you put it next to, say, nursing pay scales. Starting bands of nurses are around sort of 22,000 pounds, but actually a lot of nurses are operating at bands 4, 5, 6, and they're earning sort of similar pay to junior doctors. I'm not, I don't want to get too carried away with discussing the relative merits or value to the system of an experienced nurse versus a junior doctor, but I think it's just interesting that it may not be as much as people assume that it would be, particularly if you compare that to other starting graduate salaries in other industries like finance and so forth. It's not really that high. Gandhi, just reflecting back to when we started as junior doctors, because I think this was probably a similar time. I think I was actually earning more than that, because we would routinely work jobs where, because they weren't European Working Time Directive compliant, because the hours were awful, you would often work a job where it was starting salary plus 75% of starting salary, because they were making you work 100 hours a week, at multiple points within your working month. But it meant that actually you're probably more rewarded, I don't know, 15, 20 years ago than people are today.
Well, effectively, sad, isn't it? When I was in the hospitals, I was doing a lot of band A jobs, which was I think 80% banding you would get. So you get your base pay plus 80%. For that, it basically meant that I was working almost every alternate week. I was on nights or weekends kind of stuff. So it was awful.
100-hour weeks on the rota, 100 hours a week. Yeah.
But it did mean you get a higher rate of pay as a result, and because of the inflation aspects, actually the money we earned had more value back then. Whereas now, I mean, I've seen some doctors have been putting their pay slips up on currently, and they're taking home about £1,500 a month. That's less than £400 a week. That is not a lot of money, net pay, for working in a hospital environment, looking after patients, working potentially 40 hours plus. That's less than £10 an hour. Is that what our doctors are worth?
Yeah, so I think we're hearing some support for junior doctors here, aren't we, from the two of us?
Interestingly, so Colonel Billington, lovely name there. 2016 action was a flop. Not convinced this time will be any different. Looking at how the government doesn't seem to be at all affected by the nurses' strike. That is true. There doesn't seem to have been a significant impact by the nurses' strike in terms of the motion changes with any negotiations and stuff. Although interestingly, I did see some recent news out this morning about potentially there's a 10% increase being potentially agreed for the nurses and stuff. And obviously I'll need to go back to the unions to decide whether that'll be acceptable or not. But like I said, for me, the really interesting thing that we may end up seeing is if there's a combined hospital doctors and nurses strikes. And actually, if people really wanted to have an impact, that would be the thing to have. But obviously that's going to potentially cause some significant risk and health implications for our population. And that's going to be a real challenge for many people to discuss or negotiate or arrange and stuff, because there is likely to be harm if that was to happen.
So just thinking, Andy, I was going to say the Health Secretary, Steve Barclay, seems to be trying to sort of get ahead of this issue, and he's written to the Doctors and Dentists Pay Remuneration Body, asking for a sensible suggestion on pay increases for doctors of all grades from that review body. And that review body publishes every July and has done for the last 50 years, looking into the remuneration of doctors and dentists within the UK. And it's an independent review that looks at a lot of factors and tries to set the pay increases in the right place. And he's sort of, I think, tried to get ahead of that, indicating that he feels it's their role to set this, and that will come later in the year. You know, often they make a recommendation in July, and then those recommendations are backdated back to April of that year, and that's often what happens. So I think that's interesting. An interesting thing for general practice is this letter actually highlights general practice partners as a particular group not to be included in the review this year. Just acknowledging or indicating that we are still subject to we, Gandhi and I, and other GP partners are still subject to a 5-year rolling agreement that expires in March next year around increases, and actually the increase for all funding into general practice, which is one of the main things that determines GP partner pay, obviously, is still set at 3%. For the next year, and he's asked them not to make a recommendation on GP partner pay. So that's interesting. Included in this letter is our salaried GPs. So it's possible they might get a higher than 3% increase, but GP partners, certainly given all the other increasing costs on that budget, that has to include, you know, other costs to general practice, including GP partner pay, will only go up by 3%. It's going to be a stretch anyway, but just highlighting that GP partners that are not included in the review this year.
And I think that's a key thing to note for the funding of general practice, what we're going to talk about again in one of the later sessions here. But you know, if you don't see an increase in what practices get paid, which is effectively what the partners get paid, then they don't have the money to pay for the salary doctor pay increases, and then that causes a disconnect in terms of the staff, because they're saying, well, we've got a review board that says we should be having a pay increase here, but obviously that can't be provided because the funding envelope to give that pay rise hasn't been included. And it's a really dastardly tactic that, you know, to be honest, that Steve Barclay, in my view, is using, particularly because, you know, the DDRB, although it's said to be independent, is not actually independent because it's approved by the ministers themselves. So therefore there is absolutely no independence. And actually that's a criticism that's been labelled at this whole process, that when, you know, it talks about, you know, the government seems to take its whim on whether it does or does not agree with the DDRB pay recommendations.
I believe it didn't last year, because they said 4.5%, and that's not what at least junior doctors got. I think they got 2% because that was part of a rolling deal that then expired this year.
So effectively, you know, they listen to it when they say it's a low number and they ignore it when it's a high number. So what's the point in the purpose? And actually, if that's the case, the DDRB are also culpable in terms of the pay restoration impacts that have happened because of the fact that actually they've made some of those recommendations. They've clearly not been followed through. And actually, what is the value of an organisation that's meant to be independent that has no merit in that respect? Sorry, I'm being a bit lambasting today, aren't I, Andy?
A little bit. I have to rein you in. Just going to give a shout out actually to the DDRB's document. Actually, sadly I haven't looked at it in previous years. It's actually a very comprehensive report on the state of the workforce. I haven't sort of looked and fact checked where they get their facts and statistics from. But it provides a really interesting assessment, including graph and tabular information about numbers of staff at certain grades, full-time equivalents, applications to medical school and training posts and training schemes, and how many applicants per place and so forth. So the demand for those roles. So it's really quite an interesting read actually, and maybe one day we can pick it apart, Gandhi. But I don't think that day is today.
No, I suspect the one that we probably will want to pick apart is the next recommendation they make, because that's going to be I think the really controversial one. Because as we mentioned, the question is whether the government will listen to it or not. And that probably is a good one for us to have a look at. Interesting comment from JC Melody, regular of our podcasts and YouTube channel and stuff. According to the media, it's crunch time for the NHS, 2023 being the year that makes or breaks the NHS cert. Now, how likely is this? Is privatisation an actual possibility? Who knows? We will find out. It's definitely feeling like this is going to be the year that things, well, I think many people feel it's already broken, but actually comes to a grinding halt potentially. So we shall see what happens, I think.
Yeah, I don't know if that would even solve the problem. The problems.
Yeah.
Really, I think the country probably needs to increase its health spend, in line with other countries that we expect to have similar healthcare to. And whether that's via a government system or a private system, I think it's just the funding just needs to go up, I guess. But again, probably a detailed talk and discussion for another day. Very interesting question.
Absolutely. So speaking of our next discussion then, Andy, so we had, unfortunately, a really upsetting news story that happened recently, and it's actually quite local to me and you, isn't it, Andy, in terms of one of the practice that was affected. So there's a practice in Derby. Unfortunately, a patient in that particular practice went a little bit overboard, well, a bit of an understatement there, and significantly damaged the waiting areas. You can see by the images on that particular news report by Pulse Today. Apparently it was down to the patient being asked to follow a regular process in practice to organise their medication. We don't have much more details than that apart from what's reported in the news story, but clearly there's been significant damage caused to a practice and obviously intimidation and vulnerabilities to the staff as a result of it. It's upsetting, and the more upsetting part, I think, is unfortunately this is becoming more routine.
Yeah, I mean, just looking at the scenes there, it's quite. It looks like really disruptive. Just to think about the sort of behaviour that would create that outcome within the space, it must have been very scary for the staff involved. It's really, really sad.
And the other patients in the waiting room at the time, let's not forget there would have been other people witnessing this as well. So other patients, whether it's family members or friends of the index patient, or other people that are just there for their appointments. As you mentioned, the staff quite rightly would have understandably felt quite intimidated on that, not just at the time, but also the implications that actually is my working environment safe for me to keep going into if this is what happens.
Well, that's the thing. If you're a GP receptionist, on the edge, could maybe earn similar money at Tesco's. This is the sort of thing that causes staff to leave an environment, that causes staff to have time off because they've been traumatized by an event, and that has a knock-on effect to the services for all the other patients. It's not just the disruption in the waiting room on the day, although that looks like it was awful, but it's all of those knock-on effects. It's really, really difficult. And of course, I guess there's just been a difficult run of circumstances that have led to perhaps services being in a place where they do frustrate patients, and also perhaps a narrative that where patients feel they have permission to be angry with their GP surgery. So I think some of this might be related to the media narrative that's been around general practice for a long time, although we don't know the details of this individual circumstance.
And very clearly in the article, that's what the clinician at the practice identifies, that from their perspective, the media rhetoric that we've been seeing about general practice is one of the driving forces that contributes to this particular patient going to this level. It mentions that the police have been involved. I think there are many out there that feel that the patient would probably need to be prosecuted. I think there may be some people who feel, actually maybe what they do is understandable, although I personally would not be in that category. I think, no matter what the frustrations may be, there is never an excuse to do that level of violence, and let's be clear, it was violence, to any staff in that situation, whether they were directly injured or not, is irrelevant. Verbal or physical aggression is exactly the same thing, and absolutely there is a zero tolerance policy within the NHS, and the general practice is absolutely part of the NHS. But we unfortunately are seeing more of this, and I suspect there's more to come, to be honest, because that's what the media and some places are driving a frenzy towards. And when will they be held accountable? That's my question.
I don't know. It would be nice to see a more united front from government, royal colleges, and medical unions, BMA, on this and the communication around healthcare, but it's not happening at the moment. And within the context of the strike action and industrial action, I can't see it happening soon. But maybe in the future, we will see.
Maybe. It's interesting. I had a discussion with a patient recently who mentioned that, if something doesn't happen, I may end up hitting one of the members of staff. And I made it quite clear to them that actually, if you ever did that, quite rightly, you'll be prosecuted for doing that. There is never an excuse for you to say that, because of this, I may end up doing something that I'm not held accountable for. You are always held accountable for your own actions in those situations and stuff. I think they were slightly taken back by the fact that I was not agreeing with them, because it was about system pressures and stuff. And actually, that's where the line it absolutely is. Any form of aggression or violence is never accountable. It's never, never allowable, and stuff. And yeah, they were surprised that I seem to think that was a silly step for them to consider.
Yeah, that is absolutely awful. Although people threaten to do much worse, don't they? That's the sad thing is people will threaten to shoot staff, blow things up. Or even worse sorts of personal assaults on people. It's yeah. Oh well, this is not a great start to the new year, Gandhi. Let's see if we can find something to be optimistic about. Do you think?
Well, we have an interesting story, and we've alluded to this one. Yeah, well, we have an interesting story that comes through from some of the stuff we've alluded to throughout this particular stream. So we talked about obviously finances and things that are happening within the practice. We talked about the GPAS system, so the general practice alert system, and all that ties into this new story that came out, which is slightly financially driven, let's be honest about it, but is actually quite a significant story to be aware of for those of you out in general practice that aren't necessarily directly involved in practice management, that kind of stuff. But apparently NHS England have been blocking attempts by local commissioners to suspend QoF. So what are we talking about? Well, for those that don't know what QoF is it's the acronym for the Quality and Outcomes Framework. It's a method by which practices get paid money by doing various elements of health checks and other aspects of things, and it's considered part of the routine non-urgent care that contributes a significant amount of funds to most practice. So for an average population of about 9,700, which is what apparently the average size of a practice is, you're talking approximately £80,000 worth of funding if they're able to achieve everything. And not all practices do, but they achieve a good proportion of that. So you're talking easily, the cost of a couple of nurses, cost of a full-time GP, that's the cost of about 3 or 4 reception staff potentially. So if practices don't have that funds, then they obviously have a real challenge in maintaining their staffing and service provision. And because of the significant pressures on the systems, actually many practices are now saying we can't do this routine work because you're asking us to do all this other stuff to keep the system running, to see the acute care. We've seen over the past few weeks and months the pressures caused by first flu, then strep A, then flu again, and then flu again, and flu again, and now the system pressures in terms of the strikes and the impact that's having on hospitals, and obviously more care being pushed quicker to general practice, and sometimes even in safe situations and stuff. So that's having implications. So, practices are turning around saying, actually, we need support, and if we don't have that funding, we can't keep our doors open, but we can't do the work. So what's the options? In some areas, the ICB, so the new organisations taking charge of the funding for general practice, have listened and said that actually we will reassure you that you will get the same level of funding at least in the previous years. But apparently NHS England are not keen on that and have stepped in certain situations. So that we talked about the GPAS system, the GP alert system, and there's an area in Devon that piloted and have been running a more acute, detailed version of that is tailored for general practice. They identified that many of their practices were significantly struggling through their monitoring system, and they agreed with the ICB to support the practices by giving them the reassurance they would get, their previous year's funding at the very least for QoF and stuff. But apparently NHS England have stepped in and said, no, you can't do that. And that's an interesting development, to be honest, if it's true.
Yeah.
Allegedly.
Yeah, I know that ICBs around the country will be exploring ways of supporting general practice through a difficult period, and in doing so, encouraging them to focus on meeting acute demand, which is really what a lot of the concern about healthcare is about at the moment. And it sounds like a full suspension of QoF, is not possible. But I know ICBs will be still exploring other ways that they can sort of protect or guarantee income or reward the sorts of behaviours where they're rewarding a focus on acute care. I don't know if you've seen anything or come across any, any suggestions or any ideas about how they might do that, short of suspending QoF. I'm not quite sure.
Well, I think that's the challenge, isn't it? So QoF is, the two biggest income streams practice have is their GMS funding, which is the base set by NHS England, and it's unlikely an ICB will have the ability to adjust that locally. That has to come from NHS England, and they've made it clear there's no adjustments in that happening anytime soon. The other next level of funding, which is being impacted by the current situation, is QoF, because you can't do routine care if you're being diverted towards emergency care all the time, and that, protecting that pay would allow practices to focus their attention on other areas. This has happened in the previous 2 years since COVID started. It's important to note. It's not that they can't do this. They have done this actually in 2022 and in 2020 and 2021 and 2020. No, that's correct. Yeah, they've done it for the past 2 years. And that's because of the vaccination efforts and the COVID impact and stuff. So it is within NHS England's gift to do. Obviously, there's a question on the finance, where that comes from and stuff. But the fact that they're blocking the ICBs from doing this is a significant step, because actually the whole point of the change in the healthcare system was about providing localised based healthcare, and stepping in to say, actually, we don't want you to do that is an interesting step to say the least. The other interesting part is that with a lot of the funding being transferred from QoF to the Impact and Investment Fund, which is potentially larger pots of money for networks and stuff, that is completely within NHS England's domain to do so. And they've made it quite clear that there is no pause of IIF work going to be done. So actually, I think there's a lot of practices that are going to see a significant reduction in income this financial year. And that's going to have more of an impact, I think, than some of the other stuff that we're going to see and that we've talked about, in combination with things like pay rises, cost of living increases. So I made a prediction that I think we're going to see a lot of practice shut. I think this is contributing to that. So,
yeah. I think the interesting thing here is, I think that whilst they're not allowing wholesale suspension of QoF, I think is the language. I suspect that may mean that we find that individual areas are perhaps given the opportunity to submit plans whereby certain elements of QoF might be suspended or protected, in return for certain demonstrated actions by practices to show that they are supporting acute demand. My prediction is that we'll probably end up with something like that happening, and it might look a little bit different in different parts of the country. The trouble with all of this is that people are trying to earn their QoF income leading up to March, and for all the time that there isn't a plan to use that funding to support acute demand, practices are not supporting acute demand when they're in the midst of the crisis. If they want to do something to shift QoF income to support that activity, we need to know about it right now so that we can actually support that activity. It's just delaying like this does no one any favors, and doing some, after the event protection of certain areas of QoF to protect income, this is the opportunity to actually divert the activity. So as ever, I'd like to see more action more quickly.
Yeah, I mean, we saw this with the acute respiratory illness hubs that were miraculously funded for just before the Christmas break and stuff. So for those viewers that have not been aware of this, or if you're not, literally just before the Christmas bank holidays, NHS England, the ICBs were allowed to use certain funding to create acute respiratory illness hubs because of the significant challenges we were facing with acute respiratory illness, strep A and all that kind of stuff. And they had to be, stood up for 15 weeks, basically taking us all the way to March. A certain amount of funding, which is considerably less than last year's winter access funds that we had available to us. But it was like nobody knew that this was going to happen. Whereas everybody, boots on the ground, grassroots, frontline staff could have told you this was going to happen. We knew it was going to happen. We knew there'd been excessive demand on general practice and the healthcare service. And yet they're giving you literally like, set it up now with no planning, no awareness, that kind of stuff. And it just shows that there unfortunately is a consistent and detrimental lack of planning that comes from the centre about how to administer and manage the healthcare system. And you know, it's just really frustrating that they don't seem to recognise this, and then everything is retrospective, and that causes more problems because actually you can't do half the stuff you could have done to prevent the problems from happening in the first place.
Yeah, they're too often caught very flat-footed, aren't they? Need to look at how they scan the horizon for problems and make decisions. Would be interesting if we ever get a chance to talk to somebody who operates at that level, to just sort of ask what leads to this sort of delayed decision making, because it'll be obvious to probably most people within the system they need to act sooner, but there's probably something structural that just prevents that from happening.
Yeah,
it'd be interesting to know
so
what that
open
is.
invite to any person from NHS England or from the government Department of Health and stuff. If you want to come and, you know, educate us on the situations behind the scenes that me and Andy are just not aware of. You know, we are hands up. We don't know the other side of the coin because we don't work in that environment. We have some minor insights in some of the roles that we do, but absolutely not in those kind of realms. If you would like to come and do that, feel free to contact us. We are more than happy to have you come and join us on this session and share your story and stuff and tell us, have we got it wrong? Or are we just, you know, tell us. We'd love to hear your side actually and stuff.
So, but what's coming up in the year that we might be looking forward to, Gandhi?
Okay, so let's look at some of the stuff that's coming up. So firstly, we know that PCNs are still here and things, and many of our EGP learners are aware that we do some various stuff around PCNs and stuff. So one big thing that we're going to identify is on the 1st of March in Nottingham, we're going to be having our PCN Plus conference. If you want to come and join us on that, so that's myself, Andy, and our colleagues Ben Gowland from the General Practice podcast and Tara Humphreys from the Business for Healthcare podcast, basically supporting and coordinating a very unique type of conference, looking an absolute focus on PCNs. This is in part with our PCN Plus course that we've been running for PCN clinical directors, but also open to the local area and nationally, because this is going to be a hybrid conference. So if you can't physically get yourself to Nottingham, you can just dial in for free and join us in terms of online and listen to the content that we're going to have, looking at the future of PCNs, looking at the stability and sustainability of primary care networks, and various other showcase information as well. And, you know, it's the 1st of March, it's in Nottingham. We've got a select number of face-to-face seats. If you want to come in person, there are only a few of them. So if you do want to come, I'm afraid you have to be quick because they are going to fill up because the room size is limited. And we're going to be providing a hybrid conference experience. I think that you're not going to get elsewhere. You know, me and Andy try and pride ourselves on the fact we deliver hopefully really good virtual conferences. We're doing hybrid this year time, so it's going to be really interesting, I think, and definitely a positive note because we're hoping there's going to be a positive spin on some of this as well.
Yeah, and Ben Gowland and Tara Humphreys are absolutely fantastic speakers and podcasters and real experts in primary care networks. So it's really great team delivering the conference. And I'm just really excited to see how the hybrid nature of it goes as well. I'm really excited. It's the first time we've done that. I think I've not attended, you know, a hybrid conference before. So what's happening? Well, we've got, so in the morning, those people who've completed the PCN Plus course will be getting together to do some face-to-face sessions and seminars, and that'll be a really exciting time. And then the afternoon, people from the general healthcare community are invited to come and join us. We should have an interesting keynote. I think speaker to be confirmed, but that will be looking at very interesting primary care network integration work happening within the health service, and then we'll have a really good panel discussion drawing on those present, but in particularly Gandhi, Ben, and Tara and myself about what's going to happen after 2024. Really interesting. I think we don't know what the discussion we'll be having in March is because I suspect we'll know a lot more about plans for primary care network funding, our staff, and so forth at that point in time. But I think that will be a really, really hot topic when we're sat having that discussion in March. So it'd be great to have as many people as we can, you know, tune in for that, you know, virtually if you can't attend. And then we'll be having a showcase of probably drawing from people from within the PCN Plus course, showcasing really great work that they're doing in their areas with their primary care networks, their wider healthcare ecosystems and their practices to support patients using the primary care network resources. And then we'll kind of pull it all together and reflect on what happened in the morning and the afternoon. But I'm really excited. So I hope people can join us.
Definitely. So it's going to be in Nottingham. It's going to be in the city centre of Nottingham, 1st of March. If you want to jump in and join us, like I said, face to face, you need to be quick because I think we've already used half of the tickets as it is. If not, then there is absolutely the opportunity to join us virtually. And obviously, regardless of when you attend, you'll get access to all the recordings and the various other stuff, as you always would do with our conference stuff that we do. But also, we talked about the impact of the operational stuff that's happening. We talked about the NHS England and its involvement with the ICBs and the QoF and all that kind of stuff and things. Well, next week, we're going to be covering a new document that's come out that is the operational guidance by NHS England for 23-24. So we're inviting you all to come in and join us for that particular document. Andy's got some elements of it right here. We've already started the pre-work on this. This is going to be a significant thing, I think, for many people involved in the commissioning of healthcare and in particular in primary care to come and watch, because this is a potentially seismic document that's going to have an impact on what you need to do for the next financial year, basically. So
yeah, I'm really excited to go through this document with people. So it's document really for ICBs, service leaders, about where the NHS England think that the priorities are for the coming year. And there's a breakdown of advice for different service areas. So there's some really, really useful tables, and then there are some evidence-based suggestions about how to make improvements in these areas. So really important, if you're a leader within the NHS or operating at these levels, be great for you to join us and comment on what you think about these proposals, or this document really directing the focus of our work going forwards. And actually, if you're involved in delivery at any stage, just knowing what the leadership's priorities are and what their focus is, I think will be really, really useful as you work with them to improve care or even just keep afloat in the next year. So really excited to go through that with people next week. It should be a really good
absolutely.
session.
And if you do want to jump in and join that episode, if it's already happened, you'll probably be able to see it somewhere around about here right now, coming up on YouTube, or listen to it on the podcast and stuff. Definitely subscribe. And as always, we're here to help tech enhance your primary care and learning. We will catch you in the next episode. See you later, everyone.